fluently speaks French and English, and despite that fact is not from Canada. I would like to introduce Professor Dermot Otoole, who is an expert in GI endoscopy and endoscopic ultrasound. And Dermot worked for a long time in Paris in the group of Professor Rushnevsky, and later in the south of France, and now is in Dublin in Trinity College. Dermot, please.
Wouter, thank you very much for those kind words. I enjoyed the last presentation, which was extremely clear as well. I'll try to give you some relevant information concerning this test and how it actually affects our diagnostic skills, but also perhaps implications in management of perhaps some of you and certainly the patients in general with neuroendocrine tumors. But first, I'd like to extend my thanks to Maureen and Jim. Hello. Thank you very much for this invitation. It's been really wonderful. My first time in Canada. It's been long overdue, absolutely. And to be spoiled, literally, with the weather in Vancouver has been a great experience. And I look forward to coming back and certainly visiting other parts of Canada. And I've really enjoyed chatting with some of the patients around today, and also some of the caregivers. It's been a first time for me to be involved in a conference like this, and it certainly has been an eye-opener for me, and I've learned a lot. Thank you. Endoscopic ultrasound then, in your manual you have some lists of objectives, but to sort of summarize it in a more sort of global way, first of all, it's got a proven track record, especially in pancreatic diseases, where it's been in use since about the mid-80s, developed by Japanese, which is not surprising given their technical skills. And despite the fact that we've got advances in many aspects of other modalities of imaging, such as CT scan, multi-detector CT scan, or MRI scanning, or nuclear medicine, this technique, which is fairly simple, is essential for detecting small tumors, also for guiding surgical therapy. We have the capacity also to put a fine needle under ultrasound guidance into some tumors when it's indicated. It's not always indicated, but this can be very, very useful as well. I hope to show you that. And not only, we've heard earlier, the day before, or yesterday morning, people were talking about the use of endoscopic ultrasound in pancreas. In actual fact, as you'll see, endoscopic ultrasound is also very useful as an adjunct to guiding therapy and also diagnose in the staging of luminal tumors. And when I'm talking about luminal, I'm talking about those infecting the gastrointestinal tract, that is the wall of the stomach, the duodenum, like gastronomas, or indeed rectal neuroendocrine tumors or rectal carcinoids. And these are very frequent, in fact. Those affecting the stomach and the rectum are very, very frequent. It's also got an impact, although little evidence, on the management and of patients with MEN1, especially with multiple either pancreatic or duodenal tumors, and we may get time to discuss that. So these instruments, in fact, are really endoscopes, and at the end of the endoscope you've got a little ultrasound probe, which is fairly short at the end of the scope. It means it's flexible. You can get them into most different positions. They afford excellent resolution, down to 1 to 2 millimeters. 2 millimeters you feel comfortable at. You can use multiple frequencies within the ultrasound probe, which is going to give you sound waves. And as the frequency increases, you get a better definition of something close up. If you want to look at something far away, 5 or 6 centimeters, let's say, from the stomach, like a lymph node, you decrease the frequency and you get better resolution on something far away. There's a systematic approach that I won't have to go through, but for the physicians and the audience, it's important that you really have a thorough technique where you examine the stomach, the duodenum, the lymph node areas, using multiple frequencies. And sometimes you may have to use techniques like hyperinflation of a balloon to judge where the tumor is situated, let's say in the gastrointestinal wall layer, or even put in some water, etc. And we also have what we call very high-frequency mini probes, which go through the endoscope, the channel of a normal endoscope, so that we can put them beside a small tumor, and these can also be useful in staging purposes. So this is really what it looks like. In fact, it's you can see in the top right-hand corner with this typical radial array scanner, which really gives you images in a 360 degrees. It's a circular image processor. The one below that is a linear array endoscope, which gives you classical ultrasound images, and as you can see, coming parallel, perpendicular rather, to the actual tip of the endoscope, and this allows us to actually visualize a lesion and put a needle into it for biopsy technique, or even deliver some therapy if we get onto that. The endoscope goes through the esophagus like a standard gastroscope, positioned in the stomach or the duodenum to look at the areas of interest. And this is what we see, if you can turn on the lights a little bit. We see here, this is in the stomach, and what happens is pretty high frequency probe. We can see the layers of the stomach. This corresponds here to the area of the mucosa, submucosa, the first layer. Then we have the muscularis propria, the deep layer of the stomach, this black line, and then the outer line, there are 5 layers in this here, corresponds to the actual outer lining of the stomach wall or the esophageal wall, and this is depicted here in histological representation. So how does this help us? What happens is that if you see on the panel down below here, we've got this, you can see the layers here again, these layers, and we've got a small little gastric tumor which is located in the superficial layer of the stomach, which is the mucosa. So this is a very early lesion. Whereas this patient here, you can see clearly this small tumor, although looking very banal on a standard gastroscope, has gone through the first 2 layers here, so the mucosa and the submucosa, to involve the deep muscle layer. So this actually has probable prognostic, but certainly therapeutic implications, because you would have to send this patient, if you wanted, for a section, local resection, laparoscopic sleeve resection of the stomach, which would be recommended, and an endoscopic removal would not be possible because it won't lift off that layer simply. It's technical, but it's useful information. The other thing about staging here is you see a very small tumor. It's not even 1 centimeter, and it's again located in the actual superficial wall. Not having the pointer doesn't help me, and that camera. But where the round dot is actually now, that's the tumor. It's a superficial tumor. But just below that, outside of the wall, we can see clearly identify a 1.3 centimeter lymph node. So here, using a very simple technique, we've got nodal staging in a patient with a gastronoma where none of the other techniques actually showed up. So you're talking about very small lesions, but here we've already got node-positive disease, which may influence your therapeutic management, of course. When you get on to non-luminal tumors, the tumors then sitting in the pancreas, we put the endoscope into the stomach and we put it into the duodenum, so we can see here the yellow organ behind, which is the head of the pancreas, neck of the pancreas, and the pancreas is sitting in here behind the stomach. And we get very nice images here. This is the supramesenteric vein and the portal vein in the head of the pancreas, and you can see this tissue here, which is nicely depicted, is actual normal pancreas. We see the same thing down here with the common bile duct here in black, and the one below it is the main pancreatic duct, so you can see very fine detail. And out here we have the kidney, the left kidney. This is the probe is in the stomach, and we can see this here. This homogeneous organ is the pancreas, with the tail of the pancreas and the spleen. So this is very, very useful in getting in good positions. We can also use Doppler to distinguish between vessels and other little lesions, which can be very, very useful as well in terms of orienting and obviously avoiding any damage if you're putting a needle through some tissue to get at what we would call a target lesion. The technique is used, in fact, as an adjunct to other investigations. So we don't start, obviously, by doing an endoscopic ultrasound. So it's usually following gastroscopy, CT, or MRI, or somatostatin receptor scintigraphy as well. So it really forms part of the armamentarium in the both diagnostic and management algorithms. And so you see here, this is a standard gastroscopy here, and down here is a patient with type 1 gastric carcinoids that we were talking about earlier. This is one of the rare patients. I've got 70 patients that I follow in a 2.5-year practice back in Dublin. 70 patients. There have only been 2 patients that have had to resect, local resection. The panel discussion earlier on, I think this is sort of extremely rare that you have to perform local resection for gastric carcinoids. It does happen. And even when the lesions are slightly large, the actual incidence of metastatic disease in these type of patients is very, very low. And I agree perfectly well with Professor Maudlin with that in mind. But anyhow, this here, in fact, is useful because you can do an endoscopic ultrasound to localize the tumor. And you can see this little dark area here corresponds to one of these tumors, which is pretty small and it's well within the superficial layer. This has got prognostic implications and also therapeutic implications if you want to cut that out locally and maybe avoid more aggressive forms of therapy such as surgery, which I think has certainly been recommended with our European guidelines, as in most cases. These lesions show up as what we call well-defined lesions with little bits of rim enhancement. They're part of the characteristics. They can be sometimes difficult to see. They can be really like the tissue of the pancreas. We call that isoechoic, when it just looks like it merges with the tissue just beside it. Sometimes they're cystic, which may also have slightly, there may be slightly more aggressive forms. And the size and their intrapancreatic distribution varies. So it's important that the endoscopist knows about neuroendocrine tumors in general, because obviously gastrinomas and insulinomas are very small. The gastrinomas also have this predilection to be localized in very small tumors to the duodenal wall, up to 70% now, according to the NIH data. And this makes detection of these lesions very, very difficult sometimes. And other types of tumors, such as the non-functioning tumors, just to mention that non-functioning means that these tumors, although they can secrete stuff like chromogranin or neurospecific NLAs or other markers, they don't have any clinical relevance. They don't present with hyperacidity or hyperinsulinism. They're non-functional, and they can, in some cases, present a little bit later. But when it comes to pancreatic tumors now, in pancreatic centers, the vast majority of patients that we're seeing present with non-functional tumors. These are incidentally discovered small lesions on a CT scan or an MRI scan or an ultrasound performed for other reasons. So these, in fact, are very frequent. And they don't have to be very big. So actually, our practice is changing. We have to take that into consideration. Just a few examples here. You can see this well. This is a typical example. In fact, an experienced person will not mistake this for something else. This is another quite sort of classical lesion. But this one here in the mid portion of the body of the pancreas, just there, is in fact quite difficult. And these are the sort of patients that I got referred with classical insulinoma features, both clinical and biochemically. And they've had several investigations, and is a quite obvious tumor there. This is a typical type of scenario. This is in fact a patient who had some lymph nodes close to the duodenal wall, and the patient with a very high gastrin, serum gastrin was over 2,000. They had a history of peptic ulcer disease without Helicobacter pylori, the bacteria that's incriminated. And in fact, when you look very carefully, there's a tiny little lesion here on the duodenal wall, which was proved surgically thereafter to be the site of the gastrinoma. So what is the documentation that these techniques work and in detecting primary tumors? First of all, I'd just like to say about insulinoma, it's one of the best indications for endoscopic ultrasound. When you look at the overall sensitivity in detecting these tumors looking at non-invasive axial imaging, CT scan, MRI, or ordinary transabdominal ultrasound, we don't get very much better than about sort of 50%, let's say, overall. Somatostatin receptor scintigraphy or octreoscan scan is about 50% positive, and this is because of two reasons. One, those receptors, the type 2 receptors, are not expressed in the insulinomas. You remember somebody was saying that earlier. And the second thing is that these tumors are also very, very small, and this obviously affects the performance of scintigraphic imaging and PET as well. There's another technique where we put little catheters into the celiac artery and do arteriography with some sampling following injection of calcium. And this, in fact, is a good technique to prove the diagnosis. It's quite invasive. It can be used still, but it doesn't give you a precise localization of the tumor. Endoscopic ultrasound in good hands, it's over 90% detection rates, and it's superior to other forms of investigation. And what's really important about this, in fact, and this is the point I want to make, is that you can actually accurately localize, and this really helps enormously the surgeon in planning a resection. You can see how close it is to the main pancreatic duct and other areas, and you can try to really plan what we would refer to as a limited resection of pancreatic tissue to avoid, obviously, the morbidity associated with more aggressive forms of therapy. This is just a small series here, in fact, about 30 patients where endoscopic ultrasound helped the surgeon plan decision-making for either enucleating or shelling out a small tumor or performing limited resections like distal pancreatectomy. And in fact, for the most part, this is the case, and this can be performed more and more frequently now using minimal invasive techniques such as laparoscopy or laparoscopic assisted. Here's a 42-year-old man with recurrent episodes of hypoglycemia, where all other imaging, in fact, was negative. I have to say that this was a difficult tumor to find, and I'm showing you, it looks obvious now, but in actual fact, there was a lot of manipulation of the technical equipment to get it to a nice image. But there was a clear, pretty small lesion just in front of the portal vein in this patient. The calcium stimulation was positive in this patient. It was difficult, but the location of the tumor was not really accurately defined in terms of the calcium stimulation test. We couldn't say it was on the right side or the left side. In fact, it was in the middle, and this helped, in fact, in planning surgery. This is another case of a very small insulinoma patient with hypoglycemia and 2.1 and a very high insulin, which again, and all other investigations were negative, and endoscopic ultrasound was helpful. This patient is going for surgery next week. What about gastrinomas? Well, as I mentioned, these are more complex tumors because they're heterogeneously located within the pancreas, but also especially in the duodenal wall. Despite the fact that they're very small size, they've got a slightly more aggressive biological behavior because they have a more frequent incidence of lymph node involvement. So you get peritumoral lymph nodes are frequent. It's also obviously rendered more difficult because multiple endocrine neoplasia occurs in about 1/4 of patients, and there's a lack of recent data comparing EOS to conventional imaging in this area. So our performance, in fact, is less good. We're talking only about, at very best, 60%. When we combine it with somatostatin receptor scintigraphy, we get results that are probably to the order of about 90%. I won't go through those. They're not that important. But this is the type of thing you're talking about. This is a typical gastronoma, although you see many little nodules in the duodenal bulbus, the first part of the duodenum. So it wouldn't be, outside of a clinical context, you would not necessarily evoke the diagnosis of a gastronoma. But this is the case in this patient who was recurrent peptic ulcer disease and diarrhea, which was stopped by putting the patient on proton pump inhibitors. And we can see this is clearly located at the duodenal wall without lymph node involvement in a sporadic case. We have made some improvements as well to how we actually detect lesions, but also how we can predict biological behavior using contrast enhance. And we were hearing about CD31 and CD34. These are markers of vascular markers at a more biological level, but you can actually measure how vascular a tumor is by using contrast enhanced. So you give injection of a contrast medium that's going to be taken up in the pancreas or in the tumor, and in fact you can see the distribution of the vasculature within the tumor, and this can be used to help predict, and some interesting data to say that tumors that are very homogeneous down here on the left-hand side in A panel A are in fact very benign. Those with more heterogeneous vascular enhancement tend to be in between, and those with no enhancement tend to be poorly differentiated. So you've got real-time imaging. The same thing has been shown on contrast-enhanced CT scan and MRI, which is very useful. So this was the first case was a homogeneous enhancement. This one here is a lesion with some cystic changes, which is seen at the macroscopy after surgery. And you can see that there's a very heterogeneous blue and orange-yellow uptake, and this corresponds to a tumor of uncertain origin. I mentioned also the value of EOS-guided fine needle aspiration biopsy, and to do this, we place the scope in the duodenum or in the stomach. We can find the target lesion, and we can guide the biopsy needle straight into the target lesion, which is great. And this is pretty simple, and it's safe, and it provides both cytological and histological diagnostic proof in cases where this is necessary. And it may allow you, obviously, to complete your staging workup in many cancer situations. The results are good. We get about to about the 80% precision level. It's sometimes a little bit difficult because there's a lot of blood. They're vascular tumors, as you'll know, and sometimes this makes the actual interpretation a little bit difficult. And when do we need to do a biopsy? The biopsy would be in cases where the actual diagnosis is in doubt, or where surgery is at risk. For example, one of those small little non-functioning tumors that are just incidentally discovered in a patient maybe with a lesion in the head of the pancreas, you may perform a somatostatin receptor scintigram, an Octris scan, and that's negative. The CT scan hardly shows anything, a slightly little blip. And I think before taking out the head of the pancreas, I know that my surgeons, both in Dublin but also my former surgeons, pancreatic surgeons, they would ask for a fine needle aspiration biopsy to confirm before going on to maybe embark on high morbidity and sort of fairly difficult surgery. And there are many other cases why this would be useful. But it's also got a very low complication rate, and it's highly specific, even though the sensitivity is slightly low. And the type of things you get is not only cytology, which is actually cells in solution or in suspension. We can also get a fine core of needle, even though it's really, really small and thin. You can do very nice immunohistochemistry with staining on this, looking at all of these markers that's been mentioned several times over the last few days. And there have been a few studies looking at the impact of biopsying these tumors, especially in patients with non-functional lesions or incidentalomas, as they're called. And in fact, this has been found to be quite useful with an overall sensitivity rate in about 85%. It has been mentioned on a few occasions that analysis of K67 has been useful for predicting biological behavior, but there is quite a variance in terms of how good this is. We can do this as well on fine needle biopsies from endoscopic ultrasound. However, we can see when you compare inter-observer agreement, there is a variance. So when it's very, very low, we've got a pretty good kappa. That's how accurate the one pathologist is in comparison to the other, is about 0.8, which is not too bad. And once it gets over about 15%, this marker, it's also pretty good. But in between about 2 to 10 or 15%, we see that the actual results of the inter-observer agreement decreases. So there's certainly room for improvement there. When you look at how your biopsy obtained using this technique, how it influences down the road management or biological behavior, this has been recently shown in a paper in November 2009 that you can actually predict overall survival according to World Health Organization classification, a slightly older classification, but it can be useful as well with obviously some caveats. I mentioned that endoscopic ultrasound can also aid in guiding therapy. And this is the case that I showed you earlier. This is a patient with a type 1 gastric carcinoid, and this patient had what's called chronic eutrophic gastritis, which was immune-related. They had antibodies to parietal cells, high serum gastrin, and low vitamin B12. The patient was absolutely perfectly well. This was incidentally discovered, 43-year-old lady. So I saw this patient from a colleague. I did the endoscopy. You can see these lesions. Some of them are getting close to 1 centimeter. An endoscopic ultrasound, they're all superficially located, and she had a half-hour resection of these using an endoscopic mucosal resection. So this is the lesion here, completely resected with a safe margin. It stains for chromogranin A, and we're able to get this patient back to a level where she had microcarcinoids in her stomach and no tumors approaching a 1 centimeter side. In our ENEDS guidelines, in the European guidelines, the recommended therapy is endoscopic resection once these tumors get to a certain size. Out of 70 patients that I follow currently, only 2 have required endoscopic resection. The vast majority of patients have very small lesions that don't need either somatostatin receptor therapy or analog therapy or other forms of therapy. And our current practice is to follow these patients every year or perhaps every 2 years if they're younger. And if the lesions get bigger, we can cut them out. So this is just obviously confirmation here of the EMR specimen in this patient. Very low number of mitoses, and the K67 was probably less than 1%. It was very low. This is another case, in fact, of a patient that I saw, slightly larger lesion, and when you can see an endoscopic ultrasound, it's involving the deep muscle there, and I think that this, in fact, was probably a patient who was going to have what we would call a T2 tumor on a T staging, and I thought this was going to be incomplete. The mucosal resection looks pretty good, but I mean, how can we tell? This is microscopic disease here, and we've got to analyze the resected specimen. And the resected specimen shows that there's involvement of the deep inked margins here. When this is blown up, you can see the blue here is where the ink is, right at the resection margin, and you can see tumor cells going to that level. Predictably, in this patient, it was slightly higher Ki-67, and of the very few patients that I've seen to have to go on to get surgery, we've recommended local resection of the areas that are unresectable at endoscopy. But I predict that this patient will be telling me interesting stories in 20 years' time. We can do the same thing for rectal tumors, rectal carcinoids, and I think the take-home message here is that using endoscopic ultrasound before resecting rectal carcinoids gives us a much better result in terms of oncological resection. Got you. This here is a comparison of in a Japanese series. If you compare, I think there was about 20 patients in Group A, and they used endoscopic ultrasound before going on to resect using endoscopic methods, to a more historical group that didn't have the endoscopic guided therapy. And the take-home message was you get 100% of complete resection looking at the histological margins as compared to about 70% in the other group. So it's important. And I think that this, again, is an area that's fairly common in sort of everyday practice, where you gastroenterologists get referred people with small lesions that have been removed. You ask for the histopathology specimens to come to you from the outside institution, and you can see that the deep margins, in fact, are not clear. And it's a bit of a dilemma. And it's a lot of stress for the patient. So I say now, if you're worried about a small lesion and you don't know how to do it adequately, please send the patient, and we will try to work them up in that way. I won't have time to go through EUS and in asymptomatic patients with MEN1. Suffice it to say, that if what we've been doing currently, in fact, in Europe anyhow, well, not in all parts of Europe, but in the majority of Europe, is that patients with the NEM1 defined tumors, we've been subjecting patients to endoscopic ultrasound as part of a detecting method, and I'm sure lots of you are aware of that, and that can be very, very good in localizing very small tumors. And probably more importantly in terms of management is looking at evolution of these tumors over time, and as they get bigger, what is the best method to actually follow these patients with. And if you look at different size criteria in terms of when you intervene and resect tumors, in Europe it's about a 2 centimeter size. It's the same as in the NIH group. And we've found that with the French group that I was working with, that endoscopic ultrasound is probably an excellent method of following these patients and looking for small changes in tumor size. Admittedly, limited data, and the vast majority of patients, if you follow this graph, the vast majority of patients, in fact, the tumors didn't change with size over time, but some did. And in fact, some of these patients then would go on to have surgical resection of these lesions that are slightly larger. It's a complicated story, and it's certainly not fully resolved. It may be that newer quality, higher Tesla MRI scanning will give us more information and allow us to follow these patients with greater ease and less intervention than with endoscopic ultrasound. I'll just finish up that I think that just to show you that EUS is an accurate method in detecting pancreatic gastroenteropancreatic neuroendocrine tumors. I think with the exception of duodenal gastrinomas, where you need to get all of the clinical, biochemical and endoscopic and all of the imaging data together. This is really important, and it's really just an adjunct. For pancreatic tumors especially, endoscopic ultrasound is extremely useful for guiding surgery, especially for insulinomas. And it's useful as well in planning surgery for people with these incidentalomas or non-functioning tumors, where you can use as an adjunct as well ultrasound EUS-guided FNAB or fine needle aspiration biopsy. And although I didn't have much time to go through this, is an accurate screening tool for patients with neuroendocrine tumors as part of MEN1 syndrome. Especially if you're using cutoff criteria of 1 to 2 centimeters, where you're going to need very accurate sizing techniques. And it's also useful in screening patients with asymptomatic or asymptomatic patients at risk and following tumors over time. And as I showed you as well, I think that it's a very important adjunct in gastroenterologists' hands in guiding endoscopic resection for both gastric and rectal neuroendocrine tumors. So just finally, that to remind you that At the end of this year, the academic year 2010 and 2011 is the 300 years of celebration of the medical school in Trinity College Dublin. So if any of you folk are passing through, please knock on our door. We'd be delighted to welcome you, and we'll have lots of things going on there. And finally, these are just a few photos of the college and some eminent people coming from the alumni. Do you recognize anybody? Okay. Names, please. Oscar Wilde, okay, very good. So, Oscar Wilde down here. Who's who's this gentleman? Samuel Beckett, well done, Maureen. This down on the left-hand side. This is Bram Stoker, okay, you remember? Jonathan Swift. If I said atomized, Professor Krenning, who is that? Ernest Walton. He split the atom, or he's crashed the atom. And that's it. But there are many more anyhow, but these are non-medical people, and there's quite an interesting museum if you come to visit us. We'd be delighted to have you and host you around the college. Thank you very much.
Thank you, Jeremy.